Dr. Michael Warren currently serves as the Deputy Commissioner for Population Health at the Tennessee Department of Health. He is a board-certified pediatrician and received his medical degree from Brody School of Medicine at East Carolina University. When you talk to somebody from the Carolinas, nobody's ever said, I'm from East Carolina. It's always from the north or from the south. Maybe people say I'm from West Carolina too? Well, anyway, the doctor attended East Carolina University. So, ladies and gentlemen, those of you that have returned to the room, put your hands together for Dr. Michael Warren.
Thank you. Good morning. Appreciate the opportunity to be here and talk a little bit about our experiences in Tennessee, particularly around substance use and the MCH population. And the objective this morning is just to talk to you a little bit about what we have done and what some of our lessons learned have been, and maybe some insight into the work that you all are starting. I want to put some context around this first and talk about prenatal substance exposure. We talk a lot about opioids. Clearly, that's a big problem, but there are certainly other substances that can impact our babies as well. We have about 80,000 babies born a year in Tennessee. So in that entire universe of pregnant women, some of them are going to use substances that are potentially harmful to the baby, also potentially harmful to the mom. Those may be things like opioids or illicit drugs, but more commonly in our state, it's tobacco. 15% of our pregnant women smoke. When I looked at your statistics, it's in about the same ballpark. So important not to lose sight of some of those other substance exposures. And of those women who use substances during pregnancy, some subset of them are going to give birth to babies with recognizable syndromes or signs, things like neonatal abstinence syndrome, fetal alcohol syndrome. Some of them may appear typical, but may have subtle neurodevelopmental findings, for example. So really important to cast a broad net as we're thinking about substance-exposed children and not just focus on those with outward signs like NAS. Also wanted to provide a little bit of framework. Hopefully this is a largely MCH audience. You've heard about the life course. This was introduced to us a number of years ago by Dr. Liu when he was at UCLA before he became our beloved maternal and child health director at the national level. But what the life course says is that all of us start out with a trajectory, and that trajectory can be lowered by risk factors. It can also be pushed back up by protective factors, and it's the balance of those risk and protective or risk and health promotion factors that ultimately determines our final trajectory. So when we're talking about the life course, we're not only talking about the individual who's in front of us, but what happened to their parents and what experiences that they've had are going to impact their offspring. So it really is this multi-generational approach. And substance use certainly plays a role here. If we think about parents and substance use, their own substance use disorder, impact on birth outcomes for the children that they're going to deliver, things like prematurity, low birth weight. Maybe they'll interact with the child welfare system. But those impacts can also carry on, if we, again, think about that life course model, to their child. Maybe withdrawal, like neonatal abstinence syndrome, perhaps developmental outcomes that are adverse. That child may also interact with the child welfare system. So a number of things that can happen. And as we think about issues like substance exposure, we have to really think across the life course because each of those phases represents an opportunity for intervention. Now in Tennessee, we've got something we call our Big Four. These are collectively the factors that are having the most impact on our overall health ranking. You all know that state agencies a lot of times pay a lot of attention to rankings and how they compare with other states. Our vision is to be a top 10 state in terms of health. We've never made it out of the bottom 10. So we've got a lot of work to do. It is an aspirational vision. And as we're trying to think about how we get there, we've thought about what are those things that are keeping us from achieving that health ranking. And largely it's our Big Four. Physical inactivity, excessive caloric intake, both of those relating to obesity, nicotine dependence, and then other substance use disorders. Those are also related to our 10 leading causes of death as a state. So this one about substance use disorders is what we're going to spend the most time on today. And there are lots of very visible consequences of this that people see every day. So much like you all see here, we've got a high number of drug overdose deaths. Now more than motor vehicle crashes, now more than homicide. 4 Tennesseans die every day from drug overdoses, and that number continues to increase year over year. But there are also consequences at the other end of the life spectrum, like neonatal abstinence syndrome. So I came to this work in state service back in 2010, and a couple years into the job, people started talking about neonatal abstinence syndrome. And I wasn't that far out of residency. I did residency in the early 2000s, and I could probably count on two hands the number of babies that I took care of that were substance exposed and who had withdrawal. Lots of substance exposure, but really not many babies with drug withdrawal. And I was in a tertiary academic center. I should have seen these cases if they had been there. We just didn't have that many of them. But we had a real sharp rise throughout that first part of 2010, or first part of the 2000s, 2000 to 2010. And when folks started talking to us about this in 2012, we said, well, we're the state health department. We've got hospital discharge data. We can look at what our data show. And so this is what we were seeing. We saw that there had been a rise, but what our partners in the community were seeing was actually this, because our data was behind a year and a half. So we weren't looking at 2011, 2012 data like we would if there was an infectious disease outbreak. We were looking at data that were 2 years old, and we're trying to think about policies and we're trying to think about programs, but it's like trying to drive down the road looking through the rearview mirror. It's pretty difficult. You need to be able to see what's in front of you, and we didn't have that visibility, particularly around NAS. So we added NAS to our state's reportable diseases and events list. Every state has one of these from a public health perspective. Typically, these are things like infectious diseases that might need contact tracing or quarantine. It's a little bit unusual to add a non-infectious disease to your reportable disease list. But in our state, the commissioner has the authority to update the list as things emerge. And so we added this to the list, and starting January 1st of 2013, providers had to report this when a diagnosis of NAS was made. Now, it's important to note this is not for child welfare purposes. This is exclusively for public health surveillance. We specifically designed this so we don't have identifiable information. So if someone comes and says, give me a list of all your NAS babies, I can give them numbers, but there are no names attached to that. That was really important in getting providers to buy into this and trust that we weren't going to do something that they viewed was untoward toward families. So we made this reportable in January 1st of 2013. What you see here is the report from the week that ended November 11th. So this is November 15th. November 11th was Saturday. We used the CDC weekly reporting schedule. This is some of the most, if not the most, real-time data that you will get in Tennessee state government. So every week we publish this. The weekends on Saturday, our NAS surveillance reports are up on Monday morning on the website. And it's been really helpful to keep people updated on the incidence of NAS and what's causing it. You saw a version of this report from a few years ago in Dr. Jarris's slides earlier. The graph on the upper right shows you the cumulative incidence of NAS this year. So those blue bars represent the various weeks, and as we march out throughout the year, those numbers get higher. The colored lines that are around that show the years prior to that, so we can see if we're on track with prior years. Are we getting better? Are we getting worse? In the lower right-hand corner, probably the most important thing that we ask about is the source of exposure. And that's been really helpful to start to dispel some myths. I'll get to that in just a second. As we talk about incidence, we've seen our incidence plateau. We know that this reporting system is not perfect. It's not a perfect match to Medicaid data or even hospital discharge data. It's generally in the ballpark. But we've seen our numbers plateau. We are hopeful that means that a decrease is coming soon, although we haven't seen it yet. We do ask about exposure sources, and I would ask you to look broadly at this. There are sort of four big columns that you see. The first column, moms that are using only prescription drugs. This is far and away our largest category of exposure, about 53% of moms only using prescription drugs. If you go over and you look at the third group of bars there, prescription and illicit drugs, these are moms who are using a mix of drugs that were prescribed to them as well as illicit drugs, or maybe drugs that were diverted. So it may be prescription drugs, just not something that was prescribed for her. That's another 27%. Taken collectively, that's about 80%. So what that means is that in 80% of our cases of neonatal abstinence syndrome, mom is taking at least one substance prescribed to her by a healthcare provider. That's been a conversation changer in our state. Because when we first started talking about this, people said, well, it's those bad moms doing bad things, and let's think about how we approach it from that perspective. It's a different conversation when you say 80% of these moms are doing exactly what they were instructed to do by a healthcare provider, and their baby had NAS. This data has been really helpful in helping to tell that story. When you just look at claims data, how many cases of NAS that you had in a year, you don't get the richness of that exposure source data. If we look at those moms who are using only prescription drugs, what is really encouraging is that about 90% of them were using medication-assisted therapy, so methadone or buprenorphine. We're encouraged by that as being a sign that moms are getting connected to treatment. So I want to give an example of how that data has been used to action, and then I'm going to talk about some state-level coordination efforts, and then wrap up with some other things that we're doing in our broader MCH efforts. So this notion of how do we translate data into action, ultimately we're trying to drive prevention, and you've heard about that. Prevention is not some monolithic thing. There are different kinds of prevention, primary, secondary, and tertiary. And in public health, we really try to think about primary prevention. That's moving upstream, preventing disease before it ever happens. Vaccines, and you're going to hear about vaccines later, are a great primary prevention strategy in public health. So if we think about how that applies to neonatal abstinence syndrome, there are two primary prevention strategies. How do we prevent neonatal abstinence syndrome? We can either prevent addiction or dependence from occurring in women of childbearing age, because if you've not got someone who's using those substances, you're not going to have a baby who's born dependent. Or we can prevent unintended pregnancy. And you've heard a little bit about family planning and unintended pregnancy earlier today. In the general population, rates of unintended pregnancy are 45 to 50% for many states. Nationally, that's our average. If you look at studies that look at opioid abusing women, it's as high as 86%. And so if we want to think about preventing NAS, this seems to be a place that we can think about. So we talked with our state Medicaid agency and said, can we look at data around pregnancy intention, contraceptive use? It's really hard to get pregnancy intention data from administrative data sets, but a great source that folks have in their states are your PRAM surveys, your Pregnancy Risk Assessment Monitoring System. Your colleagues in public health can tell you how to access that, and there are great questions there that give you insight about pregnancy intent. But our Medicaid agency looked and they said, let's just get a handle on how many women of childbearing age are using narcotics. And so they looked at women who had 30 days or more of paid claims for narcotics. We're not talking about 3 days from the ER, 5 days from the dentist, 30 days or more in the past year of a paid claim for narcotic. And across all women of childbearing age, and they used 15 to 44 as the cutoff, about 10% more than 30 days of paid narcotics in the last year. Only about 15% of them had an identifiable claim for a contraceptive, meaning 85% did not. Now, some of those women may have been getting family planning services from other places. They may have been coming to our health department, getting family planning services through Title X. They may have been cash pay or paid through something other than Medicaid. But that's a big gap, 15% versus 85%. It let us know there was opportunity. And so a number of our health departments, we're a largely rural state, and so a number of our health departments have partnered with folks in their communities. This slide depicts work that's been done in local jails. We were actually approached by local jails to come in and do health education sessions. And one of the things that we found is that inmates were very interested in services that were offered through our local health departments. One of those is family planning. And so when inmates are discharged, they can get a referral to their local health department for services. We actually have a few jails where we actually co-locate services. So one of our health department nurses will come in and provide services. This has been very successful, has spread across the state. I will tell you one of our lessons learned has been you have to be really thoughtful. In general, we are thoughtful when we talk about family planning. We don't like to talk about family planning in Tennessee, but this has given us an entree to be able to talk about it because people, for some reason, are more comfortable talking about family planning in this population. So we use it as a door to come in and talk about family planning for the broader population. But when you're talking about vulnerable populations, and people who are incarcerated certainly qualify there, you have to be really mindful of coercion. And so we've worked very hard not to have even the appearance of coercion with these educational sessions and referrals to family planning. Just know if you're interested in something like that, there's some ways to be really thoughtful. We've had our federal partners from Title X come in and look at this. They were very comfortable that there was no coercion. We've had an independent university evaluator look at this and actually interview clients who receive these services. So we've taken those steps to try to get those external, hopefully unbiased observations, but it's something that you have to be mindful of. We've also worked with our local health departments to implement the One Key Question initiative. And that one key question is, would you like to become pregnant in the next year? If the answer is yes, the conversation becomes, what are you doing to make sure that pregnancy is as healthy as it can be? If the answer is no, what are you doing to prevent an unintended pregnancy? And so we refer to those effective methods of contraception. And back to the coercion discussion, it's really important to say, here's the range. What works for you? We talk about LARCs a lot. Those are certainly the most effective methods, but those methods may not be right for every woman, and you have to meet her where she is, you have to meet her male partner where he is, and you have to offer them that broad range. And so again, as you're thinking about not coercing, important to think about offering that broad range of methods. So important to this effort, that's an example of some local level work that's been going on, but important also has been state level coordination. So in 2012, when we started this work, we convened a subcabinet. These were commissioner level appointees, so those are cabinet level folks who report to the governor, who committed to coming together at that time once a month to think about how we're working together to address this. So public health was there, child welfare, Medicaid, human services, our children's cabinet, mental health and substance abuse services, all coming around the table to say what can we do, and as much as we can to think about primary prevention. Just as an example of something that group did early on, we requested a boxed warning from the FDA. We specifically asked them to put a warning on opioid analgesics that said use of narcotic analgesics in women of childbearing age may cause neonatal abstinence syndrome. Really, we wanted that as a conversation starter between a provider and a patient to say it's important that you know about risks and benefits. If you've ever been around the acne medicine Accutane, you know that there's a lot of counseling that goes on if you get a prescription for Accutane. You have to have conversations about birth defects. You have to talk about contraception. Patient has to be very aware and in fact sign documents saying I've been made aware of these risks. So we wanted there to be a conversation starter with these patients. And we got a very lukewarm response from the FDA. It was sort of like, nice health department, sort of pat on the head, thank you for sending us this. And so we were persistent, and over the course of the next year followed up with another letter. 43 state attorneys general followed suit and requested the same thing. And in 2013, in September, the FDA issued a boxed warning on opioid analgesics that were extended release and long-acting. So I mentioned several different agencies came together. Child welfare has been at the table, and Dr. Jarris referenced this earlier. Children who are substance exposed, particularly those with NAS, are overrepresented in our child welfare population. If you look at kids who are on Medicaid, about 1.5% of them will end up in state custody throughout the first year of life or at some point during the first year of life. But for babies with NAS, it's much higher. It's about 1 in 6. So our child welfare colleagues have been very interested, as have our Medicaid colleagues. And one of the reasons that they're interested is this is a large cost driver for them. So in our state, Medicaid covers about half the births. Again, we have about 80,000 births a year. The total infant spend for babies on Medicaid, this is throughout the first year of life, is about $400 million. So for all those births, they cover about $400 million throughout the first year of life. NAS babies make up about 2.5% of all of their infants, but the spend on those babies is $53 million. $53 million out of $400 million. So it's about 13% of their cost for a much smaller fraction of their population. So they are very interested and motivated in thinking about how we might address this from an economic perspective as well. One of the things they've done is to look at how we can implement prior authorization requirements. So for opioid analgesics, they've added questions to the prior authorization that ask about counseling. Has the patient been counseled on the risk of neonatal abstinence syndrome? Have they been offered access to contraception? There's no requirement for contraception, but again, it's a conversation starter between providers and patients. Public health has also been at this table. We've got a strategic map. This has recently been updated in the last few months around how we're addressing opioids, and we're really shifting gears to address this more like we would an infectious disease outbreak. Part of that is to create some urgency. We'd gotten a bit stagnant in our response. We're thinking about how we might engage folks, and folks get an infectious disease outbreak response. Folks were really struggling with how to get their hands around this opioid epidemic, and so we have retermed this even an outbreak strategic map. There are a number of things that have happened from a public health perspective. We've now got chronic pain management guidelines. Those give providers a resource to say, how can I best approach patients? It also creates a local standard of care so that as our licensing boards have providers who are bad actors who are reported to them, it gives them something they can refer to and take disciplinary action when appropriate. We've got a prescription drug monitoring program. Providers are required to check this database before they prescribe most controlled substances. And one of the key accomplishments we've seen is that we've seen about a 22% decrease in the amount of opioids dispensed since 2012 because of providers being required to check that database. Now, we've not seen the decrease in our overdose deaths. We've seen, like many states, the switch to heroin, fentanyl, and some of the newer fentanyl analogs. So still some work to do there, but some great progress on the prescribing front. There have been a number of related laws, and I'm not going to go through all of those, but I do want to make the point that you really have to come at this from multiple perspectives. So there's laws on prescribing, on dispensing, on pain management clinics, on treatment, more recently around naloxone and availability of that as a resource for folks who have overdosed. Finally, I'll close on the public health side by just saying we want to also contribute to our understanding of this condition. There's a lot of concern about long-term consequences. The literature is pretty mixed. So this is Dr. Mary Margaret Phil. She's a med-peds trained physician, EIS officer who was assigned with us, who linked public health, Medicaid, and education data all together, which was pretty unusual in our state to do a three-way data linkage like that. But what she found was that babies with NAS compared to babies who did not have NAS were more likely to be referred for a disability evaluation, an educational disability, and more likely to have a diagnosis, particularly of speech and language impairment. So some other efforts, this doesn't happen in a vacuum. Families don't wake up and say, you know, I'm just focusing on NAS. They've got lots of other needs. And so we have thought broadly about how do we continue those core MCH services as a way of addressing the needs of this population. One of the things that I'm really excited about has been our Building Strong Brains initiative. We have been focused for the last 3 years in Tennessee, and this is an initiative led by our governor and first lady. He has put $1 million, $1 million plus, in the last 2 of his budgets to address ACEs awareness and to start to change practice of folks around ACEs in communities. Some of that has been around helping people understand typical brain development and the impact of trauma. Some of it's around changing provider practice, moving from, you know, what's wrong with you to what's happened to you and how can we think about approaching you. So this has been a huge investment for us. We've also worked on something called KidCentral TN. Believe it or not, this is actually a state government website. State government websites usually, at least in our state, are not this splashy. But this is easy for families to access, and they can go in, they can put in their zip code, and they get resources that are local to them. They also get vetted information about health, education, and development. So it's been a way to help reach parents. There's a digital version of this in the form of an app that folks can use. There's a developmental milestone tracker, and that's been very popular. I mentioned tobacco earlier. Again, we have about 15% of our pregnant women who smoke in Tennessee. The Tennessee state seal is over on the left-hand side there, and our motto is agriculture and commerce. And above that word agriculture to the right is a tobacco plant. And so if you think about public health, and one of our big 4, remember, was tobacco, this lets you know some of the inertia that we're trying to overcome as we try to address tobacco in Tennessee, but particularly in the MCH population. So we've done Baby and Me tobacco free, and I know you're going to hear about that later today. We've also got our state-funded Quit Line. We've invested a lot of resources in breastfeeding and how do we get babies and moms connected with the supports that they need. This is the optimal start for families. So we've done everything from public awareness. That image on the bottom is actually a billboard. So if you drive through downtown Nashville, it is massive, right beside Interstate 40, seeing this breastfeeding mom and the number for our hotline. We've got a 24/7 breastfeeding hotline. We get about 500 calls a month. When I first came to the department, I was very curious. I'm a pediatrician by training, and I said, what are we doing to support breastfeeding moms, particularly those who have questions? And they said, well, someone in WIC will answer the phone from 8:30 to 4 Monday through Friday if moms have questions. That's great, but what about 7 o'clock on a Friday night or 2 o'clock on a Saturday afternoon or any of those other times we're not open? And so we established our hotline thinking we were only going to get those very weird, esoteric questions. It's bread and butter, basic breastfeeding questions. It's great. Those are exactly the reasons you'd want moms to call and exactly the reasons you would not want moms to stop breastfeeding, because of very basic questions. So that's been a great resource for us. We've done a lot of work to engage businesses to be breastfeeding friendly, and they have the Breastfeeding Welcome Here logo, and we recently reached our 1,000th business in the state that has taken that pledge and displayed that logo. A lot of great work by community partners. A lot of work also around safe sleep, and you heard this earlier when Dr. Box was talking. In Tennessee, infant mortality, our rates are very similar to what you have here in Indiana, and 20% of all our infant deaths are due to unsafe sleep. 20%. If we could take out those 20%, we would go from being in the bottom 5 in the country to the national average for infant mortality. So this is low-hanging fruit as we think about it, and yet we know it's not that easy. So there's really been this concerted effort over the last few years We started a hospital policy project. We've got promotional materials here that you see. The big circle is something we call a floor talker. These are big decals that we place in stores. So you might be in the grocery store, you might be in the pharmacy, you might be in a hospital, and you see these decals on the floor that help remind you. So families are getting consistent messaging. And back in 2014, we partnered with our birthing hospitals, and we said, we want to help you reach families and talk about safe sleep. And so if you will implement a safe sleep policy that's consistent with the AAP guidelines, if you will do crib audits with your staff to make sure they're following those guidelines, we will give you these cute board books to distribute, Sleep Baby Safe and Snug. And so some of you may have seen this. They're published by the Charlie's Kids Foundation. We buy 80,000 of these a year. They bring them on this huge tractor trailer. They deliver them to us. We deliver them out to hospitals. And hospitals have been very excited about being able to give those out to families as a teaching tool. What we've seen, though, is that our numbers had become stagnant. In fact, we'd started to move in the wrong direction. So just 2 weeks ago, we launched what we're calling our Best for Babies Award. This is breastfeeding, early elective delivery, and safe sleep for Tennessee babies. And to get this recognition, hospitals have to either attain 90% breastfeeding initiation rate or 5% year-on-year improvement. So some of them are starting lower than 90, but if they're improving by 5% every year, they can qualify. They have to have less than 5% early elective deliveries, and they have to achieve a score of 90% on their crib audits, and they have to have gotten bronze level certification from Cribs for Kids on the national level. If they meet those criteria, they can be a Best for Babies hospital, and we just 2 weeks ago recognized 7 of our Tennessee birthing hospitals, the first cohort of those. And competition is a wonderful thing. We've already got other hospitals calling saying, we want to do that too. How can we do that? Other core things that are absolutely necessary: evidence-based home visiting, newborn screening, child fatality review, maternal mortality review, fetal infant mortality review. All of those last review items give you rich data to better understand the needs of your population and what's driving those adverse outcomes. So I'll close with a couple lessons learned. One is that improving health outcomes for our MCH population requires a multi-pronged approach. So we're not just focused on NAS and treatment, for example. We're thinking about those other services that I mentioned, and you've got to have multiple stakeholders at the table. 2, state-specific data is very useful in engaging stakeholders and driving program and policy implementation. And I want to put a caveat here. This is a little bit of a double-edged sword. So our surveillance system gets a lot of attention. These are some news clips that have appeared in various Tennessee sources. We've even got some national attention. I'm an NPR junkie. I don't know if any of you listen to NPR, but I'm driving home one day. We had done this interview for a local NPR station in Pennsylvania who was interested in learning about what we were doing. And I'm driving home, and it's All Things Considered, and I'm not paying attention. I'm in Nashville traffic, and I heard them say, Dr. Michael Warren from the Tennessee Department. I was like, what? And I hear my voice on All Things Considered, which was pretty darn cool. But they were talking about NAS surveillance in this work, so that's positive when people get that kind of recognition and acknowledgement, and people learn how to do what other states are doing. Where it has been less helpful is when folks have used this to push other agendas. So we had a law that passed a couple of years ago in Tennessee that allowed for criminalization of pregnant women. That law has since gone away, but one of the things that folks used to propel that law was our own data and the NAS numbers. And folks said, there are all these babies, there are all these babies, there are all these babies. And sure enough, we're churning out those reports on a weekly basis, the most real-time data you get in state government, and it's being used for legislation like this. So you have to be mindful, and you have to think about interpretation. So I will close with our last bullet of lessons learned, and that's those core MCH services are essential for the population of infants, children, and women impacted by substance use disorder. Even for families who may not today be impacted by substance use disorder, services like home visiting are crucial for mitigating or preventing ACEs that you heard about earlier, and really getting all families on that healthy trajectory for their best start in life. So thank you for the opportunity to be here, and look forward to talk with some of you later today, and happy to answer questions that you have after the panel. Thanks.